All right. Welcome back to the Sandler Law Podcast. Today I have a very special guest, my father, Dr. Sandler, a gastroenterologist of over 30 years and now a retired gastroenterologist. Um, so today we're going to be talking about the little bit of a different topic than usual on the podcast. We're going to talk about the increased occurrences of colon cancer in younger people. Just before we begin, if you like the podcast, please like and subscribe, support the channel. I'm the managing partner of Sandler Law, a Miami litigation firm. To check out my firm, please visit sandlerlawpa.com. All right, without further ado, Dr. Sandler, welcome.
Thank you so much for having me on the podcast.
All right, so why don't you just tell us a little about your medical background and kind of how you got into this area?
Yeah, thank you. Well, I've been a gastroenterologist since 1989, and first part of my career was in Baltimore, and then the second part of my career was in Miami. I'm now been retired for a few years, but for about the past 25 years, I've had an interest in the effects of some drugs on the GI tract. And more recently, with the disturbing news of the increasing incidence of colon cancer in young people, it's particularly been sparking more of my interest in possible effects and causes of why this is happening in our country.
All right, and just before we get too deep into this, today we'll be talking about a little bit more of the medical side of things. Obviously, I am a lawyer, and if anyone in the audience is kind of intrigued by this and wants to discuss legal avenues or angles, please contact me at my firm's email. It's info@sandlerlawpa.com. All right, so, obviously we talk often, and over the last 6 months to a year, I'd say, I think you've kind of developed a little bit of a theory about why there is this increase in colon cancer and, by extension, the adenocarcinomas in younger people. So why don't you elaborate a little bit on that?
Yeah, I think for the last 10 years, really, there's been a very disturbing trend in colon cancer where for most of my practice, starting in the late 80s, people in their 60s, 70s, that was the main group of people that we were treating for colon cancer. And actually, in that population, the incidence of colon cancer has been going down because of the intense colon cancer screening program that we have in this country. So looking at a graph, you would see a decline in the incidence in older Americans getting colon cancer. But very disturbingly, over the last 30 years, from around 1990, there's been a trend for individuals under the age of 50 now are increasingly getting colon cancer, and particularly in people under the age of 30, which was very rare 20 years ago, even for someone that young to be coming to the office and being diagnosed with colon cancer. So something's going on. And more broadly, when we speak about adenocarcinoma, adenocarcinoma are cancers of the cells that line much of our GI tract, um, the bile ducts, the pancreatic ducts, in the lungs, the esophagus, stomach, etc. And interestingly, not only colon cancer, but these other adenocarcinomas is also going up in the younger cohort, that is, in the people that were born around 1990. So it's, even though colon cancer is the most significant cancer, it's gone from really not even being on the charts as a cause of as a cause of cancer death in young people 20 years ago. It's now become the number one cancer killer in individuals under the age of 50. So that's alarming. So there's been a lot of discussion in research circles and in the lay press even as to why this is happening. And it boils down to lifestyle, obesity, smoking, all of the things that we've been looking at for really a generation or more as the cause of why people are getting sick in this country, particularly at a younger age. Uh, and although these things do provide sort of a background for perhaps increasing problems with cancer in the country, I really don't think that those sorts of general uh, ideologic or environmental factors really hone down on number one, why is this happening since around 1990 specifically? In other words, smoking, obesity, all of those things have been around for decades before that. And also, why is it just happening in people, in young people with adenocarcinoma? That is, there's many kinds of cancer that people can get. There's blood cell cancers like lymphoma, leukemia. There's brain cancer. There's something called squamous cell cancer, which uh, lung cancer is oftentimes squamous cell, esophageal cancer. Uh, those kinds of cell types have not been affected in the same way that adenocarcinomas have been. So I think it deserves a little more scrutiny than lifestyle changes.
And just to be clear, the increased instances of cancer in young people, that also includes, for example, lung cancer, but it's clearly not lung cancer that's associated with smoking, like the old time cancers of the late 90s, or is it, I mean, the increase is specific to the adenocarcinomas?
Adenocarcinomas in non-smokers, yes. And the same thing with esophageal cancer. Esophageal cancer used to be almost always squamous cell carcinoma, and squamous cells line the upper two-thirds of the esophagus, and only these goblet cells or mucus cells line the bottom third. But it's in that part of the esophagus, the lower third of the esophagus, where adenocarcinoma uh, develops, and it has become more of a problem than squamous cell carcinoma of the esophagus, and also more so in the younger cohort. Yes.
Right. Okay. And so, kind of on that theory, or on that subject, so what is your thinking, and what did you kind of see when you were in practice, and how did you develop it?
Mhm. Well, I think most of my thoughts about this have occurred uh, pretty recently. Uh, so let's just sort of limit it to that. And I'd like just to get into the meat of it a little bit to get to where I think the problem lies. Number one, let's just talk about cancer in general. Why does cancer develop? And cancer develops in cells that divide and cells that are mutating their DNA. That's what cancer needs to occur. It needs dividing cells and dividing cells that are mutating. So the mucus cells of the intestine, let's for the purposes of the rest of this conversation, just limit ourselves to the colon, because I think the colon cancer has gotten the attention, and for sure colon cancer is the biggest problem that we're dealing with. So just for my own clarity, let's limit it to the colon. Uh, the lining cells of the colon uh, turnover every 3 to 5 days. So that's an amazing turnover rate. That's some of the fastest turnover rates of any cells in the body, including the skin cells. Our skin cells take almost twice as long to turn over. That is, the replacement rate in the colon is faster and more demanding than any other part of the body. And so there are what we call stem cells located deep in the crypts of the glands of the colon. Uh, and these stem cells live longer than the typical goblet cells of the colon. And these are the cells that are dividing. They are the mothers of the mother cells that produce all of the progeny that line our colon, and they constitute about 1 to 2%. So, very small percentage of the cells in our colon that are lining our colon are actually these stem cells, but they are the dividing cells of the colon. And they are the cells that are subjected to mutation. So, in cell division, we know that the chromosomes are doubled through mitosis, and it's not a perfect process. In other words, there's always some mutations that occur during the division process. So one would expect in a rapidly dividing cell the number of mutations to be greater than in, say, a slower dividing cell, because there's more chance for mutation to occur. So that's really how cancer develops. And in the colon, it's been fairly well defined by Dr. Vogelstein at Johns Hopkins that there is a flow sheet, almost a process of genetic mutation, and it's several mutations over the course of a lifetime. It usually takes decades to occur, where these mutations occur and the mutated cells survive the surveillance system of the body that rids us typically of these abnormal cells. So I'd like to then segue then from how does cancer happen to how do we fight cancer from happening? That is,
Right.
does our immune system prevent cancer from occurring?
Yeah.
And
So sorry. I mean, you termed it surveillance, which I think is a nice term, but why don't you explain a little what you mean?
yes, so in an adult, say, we have a very strong surveillance system by our blood-borne immune cells. So these are the lymphocytes. They're part of the white blood cell population. And these lymphocytes have what we call memory. So they remember what's a normal cell look like. So in the case of a colonocyte, or these mucosal cells of the colon, the T cells of our body have developed a memory as to what is normal. So when they start seeing abnormalities in these cells from genetic mutations, right? So the mutations occur in the nucleus of the cell in the DNA, but these are oftentimes manifested on the surface of the cells, which by what we call cell surface antigens. So when these cell surface antigens are recognized as different from normal, they're killed by the immune system. So that's an underappreciated but critically important part of why we don't get cancer in this country nearly as much as we would without this what we call adaptive immune system. Adaptive meaning that it takes time after we're born. So let's get to the newborn. In the newborn, this notion of what's self and what's not self, that is, what's normal and what may be becoming troublesome and becoming cancerous, that notion is not defined in early life. That the adaptive immune system uses the thymus and these circulating T cells to define what's normal, what's self. And I've made a graph behind me. I apologize, but a little amateurish, but I just want to show you that graph.
So just to explain a little bit, meaning basically what you're saying is people are not born with like hard coded cells that know what to be on the lookout for. It's more that as a baby or a child develops, the assumption, if you will, is that they develop normally, and these T cells are constantly kind of going through, and they start to recognize, oh, this is normal, and then eventually they develop a memory of this is normal and anything else is abnormal, and then they start attacking the abnormal when they see those mutations. Is that kind of a fair summary?
Exactly. That's exactly right. So how does that look?
Yeah, good. That's a good shot.
Okay. So that's if the x-axis here is age, right? And up here, if we look at the development, that is the ability of our immune system to discriminate self from non-self, normal from abnormal, non-mutated from mutated, you can see that there is a rapid rise from birth until age 20. So by age 20, we have a mature adaptive immune system. But you can see, particularly early in life, it's the percentage of the development of that ability to discriminate between self and non-self is low. In other words, if there were mutations occurring early in life, they would not be seen as foreign by this adaptive immune system, by the T cells. They would be accepted as normal, right? Because this is during very early in the surveillance period of this system. So what we need here and how we get by and how we survive this period of education by the adaptive immune system is something called the innate immune system. The innate immune system is something that we're born with, and it's made up of several components. But let's just talk about one of the major components for the colon, because that's where we're going to focus. That's the layer, the mucin layer. So the mucin is made by the goblet cells of the colon. That's what the colon lining cells do. They make and they secrete mucin. So the mucin doesn't stay in the cells. The mucin is secreted by the cells. It then adheres to the surface of the cells and forms a barrier to the luminal contents of the colon. So here you can see the mucin layer. So when we're born, right, the mucin, although it's not totally developed, it's much more developed than the adaptive immune system.
Sorry, just maybe tilt up the camera a little bit to catch the top there. Yeah, there you go.
Right. So it probably is like this, but for the purposes of our discussion, that's from the ages of 0 to 20, but particularly from the ages, say, from 0, from birth to, say, 2 or 3 years, right? The mucin layer is the main barrier that keeps the stool. And what is the stool? The stool is a combination of the products of digestion, right? Bacteria, or what we now call the microbiome, and the toxic metabolites that are secreted from the liver, right? The liver is the detoxifying agent in our body. When we take drugs, good ones or bad ones, when we drink alcohol, if we smoke cigarettes, right? All of the toxins in those substances that are brought into our body are detoxified by the liver, and those toxic metabolites, that is, at the end of that degradation, right, they're secreted through the bile duct into the small intestine and ultimately out the colon. So that's what the stool is. What's left over from digestion, the bacteria, and the toxic metabolites. Okay, so what I want to make clear from this curve is that early in life, we are extremely dependent on the mucin level, that physical barrier. I mean, it's a physical barrier. There's nothing molecular. So I'll say there's nothing going on here. There's no learning going on. It's a mucin. It's a barrier. That's what it is. So
Meaning it's just a barrier, almost if you will, that the body, however you want to describe it, it was built to deposit at it almost looks like excessive levels in the younger years, precisely because that's what's being relied on to stop toxic material getting into the body.
Yeah. The mucin has has several properties, several things that it does. One is a lubricant, right? So it provides lubrication for the contents of our anywhere where there's mucin, it lubricates it so the flow through the lumen of either the duct or the intestine, it's facilitated that way. But more importantly for our discussion, it protects the underlying cells in the colon from the toxicity of the bacteria and the toxic metabolites. Now, in the stomach, there's mucin there too. Uh, in the stomach, it really protects us from the low pH of the acid that's secreted. So it's very well known that when we lose that mucin protection in the stomach, we can get ulcers. And so people who take non-steroidal anti-inflammatory agents, et cetera, those people are more liable to get ulcers because the mucin level is diminished, and then the acid has direct access to the cells, and it burns them. I mean, it's literally a chemical burning. The pH of the stomach is down around 1 or 2, a very acidic environment during digestion. In the colon, it's never that way. All right. In the
So
colon,
sorry, just to kind of put a finer point on that. Um, and basically, I think where you're going is if there would be an external agent, I'll call it, that is disrupting the mucin levels, especially in the younger years, that would be effectively a way for the toxic material to be getting into the underlying cells, right?
correct. And particularly the stem cells. I mean, the stem cells are protected from all of this by the mucin, et cetera, by the cells themselves, right? The cells that the stem cells are making are even protecting the stem cells.
Mm.
But when the mucin is lost, then all of a sudden these toxic entities then can get in and start destroying the mucosal cells and accessing the stem cells, not only to destroy them, but also to potentially mutate the DNA, right?
Mm.
They're what we call mutagens, right?
Mm.
Bacteria and toxic metabolites are mutagens. That is, they're pro-mutating, that they enhance DNA mutation in the cell.
Mm. Okay, and one of the things you mentioned are NSAIDs or non-steroidal anti-inflammatory drugs, and so just to elaborate on that, what is their function? Obviously, there's a positive function to them, but what's the consequence as far as the mucin goes?
Right. Exactly right. Non-steroidal anti-inflammatory agents, and let's just talk specifically now about ibuprofen, right? Advil, Motrin, there's ibuprofen. Those are sort of the common names of that drug. They work. They're very helpful, right, for people with inflammation, with pain. They work through what's called the prostaglandin system in our cells, and they inhibit an enzyme that enzymes called the COX enzymes, the cyclooxygenase enzymes that convert prostaglandins from inactive to active molecules. And from there, prostaglandins are involved in many functions of the cell, very complex molecules, complex functions, but they are also very important in the manufacture and secretion of mucin. So when we take an ibuprofen for a headache or because of an injury or something like that, fever, all of those things, it has the additional effect of not only helping with those symptoms, but it decreases indirectly the mucin layer throughout our body, right? Wherever there is mucin, mucin production is inhibited by non-steroidal anti-inflammatory agents, and specifically here, ibuprofen.
Right. Okay. And so to kind of, take this to the next step, well, why don't you kind of put a point on it, which is your theory is that the NSAIDs and the use of the NSAIDs, the nonsteroidal anti-inflammatory drugs, are having this effect, particularly on younger people, and
Yes.
kind of just tie it all together.
Yeah. Okay. So here, I am particularly concerned with ibuprofen use in very early in life.
So maybe just to maybe drop it down a little, the camera, so you can see the age, the x-axis. Yeah, there you go. Yeah.
Yeah. So I'm really talking in the early years, say from birth until 3, 5, maybe 10. Again, it depends on the individual, right? But in this area, for sure, the adaptive immune system is very immature. If we take away then the protection to discriminate between self and non-self, and that's the mucin level, if we injure that, if we degrade it, then we are increasing the chances of mutations occurring, right, and being tolerated by the immune system. So I'm very concerned that by giving infants and children, young children, ibuprofen, that we may be giving these mutational effects a head start down the road of cancer to cancer. And it correlates very well with the cohort of people that are now getting these early cancers. It correlates very well with when ibuprofen became.
Sorry. So just as a layperson, as far as medicine goes, if I could maybe just summarize it the way I understand it, I mean, basically what you're saying is NSAID consumption at early ages has the effect of, at least a collateral or a symptomatic effect of decreasing the mucin protection in many organs, particularly the colon. As a result, toxic material gets into the underlying cells, in particular the stem cells, which also results or leads to mutations in those cells. And because we don't have a fully developed adaptive immune system at that age, children don't have kind of the surveillance. They don't have a developed surveillance. These mutations are allowed to occur and kind of take hold. Is that what you're
Survive.
saying? Survive,
Right.
right?
They survive.
And by extension, is it fair to say that once the surveillance does develop, the body registers those mutated cells as normal? In other words, later when the adaptive immune system does develop, they're not going to attack those cells because they've already seen them since the person was a child.
Right. They're in
Yeah.
the normal or
Right.
self database.
Right. Right. Okay. Yeah. So this is a very, look, obviously this isn't the first time we're talking about this, but I think it's becoming clear to me as we talk, and it's very fascinating and, in some ways, frightening. But so to take this to the next level, as far as kind of the empirical data, and I think that's what you were getting at as far as use over the years of NSAIDs. So why don't you explain that?
Right. NSAIDs, like ibuprofen, really became very popular in the 1980s. Uh, Many of us in my generation remember the days before ibuprofen. But in 1980, actually, aspirin was no longer used in children because of the concern of something called Reye's syndrome. So since about 1980, Tylenol and ibuprofen have been used for fever, all kinds of things in young children. And actually, ibuprofen became over the counter and approved for infants as young as 3 to 6 months in around 1989. So since that time, for the last 30, 35 years, there has just been unfettered access to a drug that uh, downgrades the mucin level anywhere that there's mucin, really. So it's certainly more complicated than that. But at 30,000 feet, that's where I'm coming from here.
And so basically, what you're suggesting is NSAIDs, ibuprofen became available on the mass market at any age, basically starting in the 1990s or late 1980s, right?
Correct.
And that's precisely so those individuals, children, newborns born in that time span are the ones that are now in their 30s. And that's where we're seeing the increase, this huge spike in colon cancer and the adenocarcinomas generally, right?
Correct.
So the population being affected by this correlates very closely with the availability of NSAIDs and ibuprofen over the last few decades.
Yes.
All right. Well, I mean, I think we've covered it. I mean, I certainly have a better understanding. Is there anything you want to add to the theory? I'll call it.
Yeah, I'll just answer the question, which is has come to me many times, and that is uh, in the literature at least, these drugs, NSAIDs, aspirin, are considered protective against cancer. In other words, the literature supports that there's some protective aspects. And I would want to point out there that those studies have not been done on children. Those studies have been done on individuals 40 years old and older. So, on the curve here, those people are with well matured adaptive immune systems. So, and it makes sense then in that population, and we don't need to get into the details of that, but it makes
Right.
sense in that age group that these drugs may be protective against colon
Right.
cancer.
Meaning, because of that, even at that age group, the mucin is less important, at least with respect to cancer prevention,
Exactly.
because the adaptive immune system is doing the job and it already knows what's normal, what's not normal, because it's got 40 years to, look back on.
Correct.
All right. Yeah, and look, I mean, I think everyone in the Western world at least knows about, Tylenol and ibuprofen. Those are the two main drugs used for fever at all ages. Um, I've certainly been recommended to use it for. I think everyone has had to been recommended to use it for fever or aches. I have children. It's recommended for children. I think what you're proposing is very interesting and frightening at the same time. So, I guess what are your thoughts, kind of going forward? Where do you see this going?
I think there's a critical need to quickly look at the question because, like you said, my children and my grandchildren are potentially in the crosshairs here. And we're talking about populations here. We're talking about millions of people. So we, I think it's an attractive theory and more specific to the conditions that we're confronted with than the more, I think, nebulous theories of lifestyle.
Right. Right. Like one of the things floated around in the current kind of newspapers and literature is carbonated drinks increase colon cancer, which I mean, look, I'm no expert, but that does sound kind of out there. I mean, carbonated drinks have been around for decades, if not centuries. So I think this theory, at least the correlation, is more stark. I'd say.
Agreed.
Yeah. So with all that, I would just like to conclude saying that, obviously we have not done studies on this. These are purely, I would call it opinions or maybe even speculation. Certainly not saying anything concrete here. That being said, if anyone listening is intrigued by this, would like to reach out to me to discuss maybe legal angles, or I could even put you in touch potentially with my father, Dr. Sandler, to discuss the medical ramifications or potentially pursuing studies on this matter, please contact me at info@sandlerlawpa.com. Once again, if you like the episode, please like and subscribe. If you want to check out my firm, please visit sandlerlawpa.com. And I'm also on YouTube at Sandler_law. All right. Without further ado, thank you, Dr. Sandler. Thank you for your time. All right.